Right, good afternoon, everyone, and welcome to the last session of the day and of the conference as well. So, I would like to introduce you to our first speaker, Dr. Duc Nguyen, who is the Deputy Director General of the Department of Science, Education, Culture, and Social Affairs of the Government of Vietnam. He's also a member of the National Committee on AIDS, Drugs, and Prostitution Control of Vietnam and the advisor of the International Technology Transfer Center in Vietnam. After the Hubert Humphrey Fellowship in 2006 and 2007 at Virginia Commonwealth University, he took over the post of the Director of the Drug Advisory Program at Colombo Plan, which is a secretariat and an intergovernmental organization of 26 countries in the Asia-Pacific based in Colombo. In 2011, he went back to Vietnam to serve the government of Vietnam. He has introduced and initiated evidence-based drug demand reduction programs in Vietnam. And before I just want to add something else to his bio, is that Duc and I did our Humphrey Fellowship together in 2006 and 2007. And our professors and mentors, Professor Bob and Prof. Randy is in the back to support us. So it's 18 years later and we've come full circle. So Duc, the floor is yours.
Yeah, thank you.
So we'll have the presentations, and after the presentations, we'll have the questions and answers.
Thanks, Rehana. Actually, more than 10 years ago, I never thought that I present at the international conference and you chair the conference when I'm speaking. And also would like to say thanks to Bob and Randy for your time with us in VCU. So today we can stand here to present to the audience about our research in the field of drug demand reduction. It's a bit pressure because this is the last session. So we are going to have the beach party and the closing ceremony after this. So we'll make it very quick. I talked to Rehana that I present about 5 minutes and we will close the session in 1 hour. Before I start my presentation, I would like to thank my team, Dr. Zhang, Dr. Chang, and Dr. Mai, who's helping me to develop the abstract and also prepare the presentation for today's sessions. Our presentation today to talk about strategies of Vietnam on drug prevention, treatment, and recovery in the last 20 years. So in this presentation, we will review our key policies of Vietnam in drug demand reduction in the last 20 years and highlight evidence-based approach on prevention, treatment, and recovery in the national strategies to address the drug issues in Vietnam. Before that, I just want to give you the picture on the drug use situation in Vietnam now. In Vietnam, the drug users and drug addicts still high, over 220,000 people, taking about 0.23% of country population. Is a high pressure for our policy makers, also for the people working in the field. And the trend of narcotic has changed from opiate and heroin to synthetic drugs. I think it's very similar in every country in the world, that now synthetic drugs is very popular in the world. So according to United Nations, every year there are about hundreds of new substances appear every year. To cope with this situation in Vietnam, the National Assembly of Vietnam has passed the law on drug prevention and control with a comprehensive approach on supply, demand, and harm reductions, with specific assignments to different agencies in Vietnam to work with. And The Prime Minister also issued the national strategies on drug control to 2020 and Vision 2030. And besides that, we have a periodically national drug control program from 2005 to 2010, from 2011 to 2015, 16 to 20, and 21st to 25th. And especially in the coming years, the National Committee and the government of Vietnam is developing the national targeted program on the drug control to 2030 to mobilize more resources and to invest more to strengthen the drug control capacity in Vietnam. It's including several projects on drug demand reduction, harm reduction, and supply reductions. Firstly, I'd like to talk about our strategy on prevention. You know the model of traffic light. Green light is prevention, and yellow light is early intervention. I'm going to talk in the next slides about the stage of the traffic light models. And when we need the intervention is when we have the people engaged in the drug use. We have to have the intervention to them. And for the prevention, we in Vietnam recently we implement several evidence-based initiatives for the drug prevention in Vietnam, including the school-based prevention, which emphasize on evidence-based manual for schools to raise awareness and equip youth and students with the skills to prevent drug use. For this program, we are working with Colombo Plan and other agencies now we are translating this as UPC, I mean Universal Prevention Curriculum into Vietnamese, and ITTC Vietnam. We are editing this manual to suit with Vietnamese situation right now. And besides the school-based prevention program, we had workplace-based prevention run by trade union in Vietnam, and media-based prevention run by several media agencies and Ministry of Information and Communication. And community-based prevention is, for the community-based prevention is very important in Vietnam because we stress, we focus on the prevention in the commune with the involvement of several agencies and several people in the community on this initiative. And we also engage youth in the prevention because in Vietnam we have youth union with this organization to involve several people to work with government agencies in several fields. So today is on the 27th of June. So yesterday was International Day Against Drug, and in Vietnam this month is a month against drugs. So in the next 2 days we have a running in Hanoi. So I hope that when we get back to Hanoi we can attend the race with the involvement of thousands of people. So we have the theme 1,000 steps for drug-free community for this Sunday run with the participants of celebrities and many famous people. A new point in the treatment and recovery in the law on the drug control of it and drug control law is we have the management of illicit drug users. It will be carried out from the first time when people are detected by using illicit drug. We call it early intervention, as I mentioned in the traffic light model. And besides that, we have voluntary treatment for drug use disorder in families and communities. It means that it's no compulsory treatment in the communities like before. I mean, in the last law of the drug control. And the last is for the recovery. There is no regulation on the post-treatment and management and recovery in the management, in the treatment facility. So for recovery, will take place in the community. It's not in the compulsory center. And for the intervention for synthetic drugs, like many countries around the world. So synthetic drugs, as I mentioned earlier, that is popular in Vietnam and other countries right now. And we apply behavioral intervention as a solution for to cope with synthetic drug use. And the cognitive behavior therapy was applied to prevent and to treat for the synthetic drug user in Vietnam. And we also have the protocol prepared by the Ministry of Health to give the guidelines to the treatment facilities and the communities. And now I would like to turn to the other evidence-based initiatives. Is a pilot model of social and legal assistance, consultation and referral service for people who use drugs. So this model actually is based from the drug treatment models that we have learned in US and in other 20 countries in the world. The pilot model started in 2017. Firstly, we would like to initiate the drug treatment court model in Vietnam. But after a few years implement, we felt that we need to implement step by step. So firstly, we carry out these initiatives as like a referral service for people who use drugs as a first stage. And then the next one with the involvement of the judge and police force and other people in the community to help the drug users in the community. We can call this pre-trial stage. And this model have promote the role of different agencies in the community to help drug users in the community and give them with some benefits, so that in the last 2 years we have involvement of 170 patients in 2 districts in Hanoi. So and after this, in the next year, we have another plan for the next stage. And of course, like many countries, we still have a lot of challenges during implementing drug demand reduction initiative. Firstly, is talking about the finance. We have a lack of public financing, lack of medical staff, and working in treatment facilities, and also lack of well-trained teachers and prevention practitioners. And of course, if we want to implement any good model, like a drug court model, we have to have available treatment facilities in the community so that we can refer our patients to proper treatment facilities. And for solution for this, as I mentioned, that we developing the national target program to 2030. So in this, we invest more money from the state to the drug control activities in Vietnam, and we mobilize local and central budget in this field. And of course, we need the capacity building for prevention and treatment practitioners. In this field, we need the collaboration and support from INL, Colombo Plan, ICDDUR, and other international organizations to prevent, to work with us on the prevention and treatment and recovery of drug. Because we know that international organizations like Colombo Plan and ICDDUR and other institutions have many research and experience in the field of drug demand reduction. So we can work with you guys to work together in this field. And I would like to end my presentation by say that leave no one behind, because uh, it's a central goal of the Sustainable Development Goal until 2030. It's not only for drug demand reduction, but also for poverty reduction and also, social issues and education, and so on. Thank you very much, and I wish you have a very good closing and beach party tonight. Thank you.
Duc, thank you so much for a great presentation and an interesting one. And I see that you've really put your Humphrey Fellowship into work and implemented a lot of drug demand reduction programs in your country, which is quite impressive. So we'll have questions after all the three presentations. And now I would like to introduce you to our second speaker, who's Ms. Faridah Nakoma, who holds a Master's of Science in Clinical Psychology from Makerere University. Since 2013, she has been lecturing at the Department of Psychology at Kiamboho University. Faridah is a co-facilitator of the UTC under the Drug Addiction Free Africa training, and she's a training provider of UTC and UPC in Uganda. Ms. Nakoma has also facilitated several capacity building trainings and workshops in organizations providing mental health services to vulnerable groups, and she's currently serving as the board chairperson of 3 Stars Rehabilitation Initiative. So it's a community-based organization in Uganda. With over 10 years' experience working with families of children with disabilities, Faridah also provides consultancy services to several disability projects in Uganda. And today she's going to talk to us about substance use disorders among female offenders in the criminal justice system in East Africa. Faridah, over to you.
Okay, good afternoon to you all. It's an honor for me to be here and to have you attending and listening. My name is Faridah Nakoma, as I've been introduced. One of my colleagues at work and I came up with, we had a question, and we were wondering about substance use and women and prisons, and we thought maybe we could do some search of what studies have been done. So what we have is a literature review we did about studies that have been conducted in East Africa, in the East African countries. My colleague is not here, but I'll ably stand in for him. So as we have seen and heard throughout the conference, the problem of substance use is still existing, and it's probably growing bigger than we can handle. It's probably running faster than what we are doing. And specifically, we were thinking about women as, of course, often underrepresented in many ways, but also in research. Issues regarding women are often sometimes, I think the slide is not moving. I'm already on the second slide. Thank you.
I'll go get the tech person.
Did it move? So we have a bit of technical problem. Okay, it moved. Caleb, thanks.
You have to close this one first and reopen.
Which one?
This one you close and
I close yours.
close mine.
Sorry. The slides are not moving. You need to close some.
Okay, where's the presentation? This one?
No.
Huh?
No. Okay. So, yes. Yeah, I was saying that there is a problem when it comes to women and research and being represented in many spheres of life. And when it comes to the criminal justice system, studies have shown that most of women who are in prisons have a connection to substance use, or they end up in prisons because of something related to substances or drugs somehow. So a lot of studies indicate that majority of women in prisons have a background of substance use. So the prison population is mostly men. Mostly over 85% of prison populations are men. So for that reason, I think a lot of studies have not been done about women because most of the findings show that the samples are small to spend probably funds and resources to research about women. And yet, yeah, like I said, UNODC findings show that substance use is a significant contributor to crime among women. So we decided to, like I said, to think of how we can find data about women in East Africa. Now, East Africa is that part that you're seeing, the green part of Africa. It comprises of 8 countries. It moves from the western part of, I think is that the Pacific, and then to the Indian Ocean, and then a bit up. When I was younger, the East African community had only 3 countries, but now there are 8. So there is Congo here, the DRC, and then there is South Sudan, then there is Uganda. Uganda is where I come from. And then there is Tanzania, there is Kenya, and then there is Somalia. Did I mention Burundi and Rwanda? So there are 8 countries in total. So we felt it's important to find this information because it's not only about the research, what has been written, but it also informs what is happening in practice, because what is happening in practice is what is going to be written and researched about. So knowing that also impacts policy, more research, and of course theory and what we teach and where we should put emphasis. Okay, why women? I think I already mentioned that. Female inmates generally have higher incidences of mental problems compared to general population. Female offenders or inmates tend to have 2 to 4 times higher prevalences of mental-related problems, substance use being one of them. And then there are twice as many as men when it comes to representation in mental problems. So studies on substance use among females would go a long way to inform a lot of interventions for women with their unique needs. So bundling them up together with men's needs sometimes doesn't help them much. Okay, so what did we do? We went on a search for information. We used Google Scholar, we used PsycInfo, we used Scopus, and a lot of those search engines. And we came up with, we focused on studies between 2014 and 2023 for all the countries. And we came up, we found about 40 plus studies that were made, but half of them didn't have what we were looking for exactly. So we eliminated about half of them, especially the ones that focused more on women being in prison because of involvement in commercial drug trade and all, and then maybe the ones that didn't tackle women at all. So when we were looking for the information, the search terms we used were prison, jail, offender, criminal. We would combine that with any one of the words in the middle section and another word in the last section. So for example, you'd search prison, substance, and Africa. And then that's how we would eliminate and pick out some of the studies we were looking for. So we went ahead also to name country by country, and also Africa in general, because some of the studies were mixed. You would find a study that was done from a West African country with an East African country and South African. So combining the word Africa sometimes would bring out the studies better. So what did we find? We found some of what was already found, that women make up a smaller proportion of offenders. From the studies, from the prevalence rates, we found a minimum of 3% of the offenders, of the prisoners, to 6.5% being the highest. We will be looking at a table which summarized that. Yes, and many times some of the studies were indicating that they did not need to go deeper into female issues because they felt the samples were small in the prisons, so they would just ignore that. And then, one of the characteristics of the women in prisons from the studies we found was that they typically come from lower socioeconomic backgrounds, which is also a finding by the UNODC, and generally dysfunctional backgrounds, low education, no employment or low earning jobs. Many of them had become mothers at a very young age. Many of them were single mothers. So that contributes to their socioeconomic standing. So majority of the reports on female offenders focused more on mental health in general, not specifically substance use. So even the ones we put in this, we could not find many that separated substance use from mental disorders or mental problems, which was also okay because, substance use is a mental problem. So there was little or no emphasis on substance use disorders among female offenders in particular. So it was mostly general prisoners, without specifying that this study is for women alone. Although some would go ahead to show certain prevalences that were special to women. Then a small number of the reviewed studies mentioned social and psychological interventions for substance use disorders, but generally they were talking about the general population of the prisons, nothing specific for women. So this table is just a bit of a summary of more of what we found. And the first column shows the studies, that the countries that had studies. There were some countries that didn't have anything on female offenders or females in prisons. So Burundi and Congo, we couldn't find any data. Same as South Sudan. And then, I think Kenya had the most studies. Then Rwanda had something. Somalia had, and Tanzania and Uganda. So those 8 are the countries that constitute the East African community. And then the percentage of female offenders out of the whole prison population, that was by 2015 from the World Prison Brief. Burundi had 4.8% of the population in prisons being female. Congo had 3. We couldn't find Somalia. There was no data. I think the lowest was Congo, and then the highest was Rwanda. Then when it came to alternatives to incarcerations and whether they are being practiced or even heard of, the X indicates that there are no laws in those countries regarding alternatives to incarceration. So probably people, I don't know if they even know that it's an option, or maybe it's just not documented. So Burundi, Congo, and Rwanda, the data shows that there are no laws to support prisoners in general, not just women, regarding what could be alternatives to jail or to punishment. And then Kenya and Tanzania had laws. That's why they have 2 ticks, but they also had practices. The law is there, but they also had like drug courts, community sentences like that. So they were practicing it. And then South Sudan, Somalia, Uganda, the law is there, but they are not yet implementing. Okay, so in conclusion, there's little information regarding women and substance use disorders in this part of Africa, in East Africa. Although it's emphasized by UNODC that substance use is a great contributor to women being in prisons and committing crimes. So further research is needed, of course, to determine a lot of things when it comes to substance use among women in the criminal justice system. What are the drivers? What are the social factors? What are factors like past trauma got to do with their criminal behavior? What are the social cultural issues involved in women being in prisons and offending? Then we need to also think about gender-sensitive community justice systems, of course. And of course, we can only do this with more studies and more work. There are a lot of special in quotes needs for females in prisons, mental health needs, sexual and reproductive health issues and their complications, STDs, HIV, pregnancy. I mean, all those are unique to women. There are women who are in prisons with their children. There are women who are sentenced when they are pregnant. Those are all special issues. Okay, so that's a list of the studies we included. And thank you. That's it.
Faridah, thank you for presenting on a topic that's very important in terms of how women are overlooked in terms of substance use disorders, especially since there's such a vulnerable population. And it's really heartening to see that East Africa is doing research in terms of how substance use disorders can inform treatment and interventions. All right, so now we come to our last and final speaker. And as I was reading her bio, it says 23 years old educator, special educator, and I misread and I thought, wow, 23 years old, 23 years in the field. But actually, she's 23 years old, and she started work at the age of 19 and has been working as a part-time lecturer at a local college. So I think she's one of our youngest presenters so far. She finished her postgraduate studies in education earlier this year and has been interested in doing research on various social issues that are ongoing in her country, the Maldives. The Maldives is a small developing country that requires research in a variety of fields, including the area of substance use. She believes that initiatives like this will put pressure on both local and international policymakers to make the necessary reforms to address such concerns in our society. So what's very interesting, it's interesting to see how, we talk about intergenerational trauma, but here there's intergeneration education and influence that has been passed on. Her uncle, Ali, has been an active member in the substance use disorders field for forever, I think, Ali. Yeah? For almost. And it's his niece that's going to be presenting. So, Luhya, I hand it over to you.
Thank you so much for the lovely introduction. Good afternoon, everyone. I'm Luhya, and I'm honored to be here. I would first like to thank ICUDDR and ISSUP for giving our team this opportunity and to be in the same room as a bunch of intellectuals. So my this research is an ongoing research titled Exploring Perspectives of People in Recovery, Peer Support Groups for Drug Rehabilitation Within the Maldivian Context. So as you can see, this is our beautiful country that is usually marketed as a paradise on earth. However, the side that people don't know is we have a substance use. The substance use issue is a growing issue in our country, and in order to combat this issue, non-governmental organizations began to develop peer support groups, which I would be referring to as PSGs, as part of their rehabilitation approaches. And the research objective is to document how PSGs are conducted and the experience of those involved in PSGs in the Maldives. When looking at the literature, we have come up with 3 titles. In history of drug use in the Maldives, the first drug case has been coincided with the development of tourism, and it has been on the rise ever since then. With the first case of drug use, with the first case came the first legislative act of the Maldives in 1977. This caused the establishment of the National Drug Agency, which enrolls people in treatment, individuals in rehabilitation programs and treatment. When looking at the evidence base for PSGs as a treatment approach, studies show that PSGs reduces isolation and brings a lot of people with similar experiences together, hence giving them a sense of belonging, which is a great approach for the Maldives, as in the Maldives, drug addiction is highly stigmatized. The method used for this study is a qualitative approach, which includes semi-structured interviews conducted both face-to-face and online. These interviews were also conducted in our native language, Divehi, and in English. A facilitator and a participant from 2 NGOs were involved in this study. When looking at the findings, one of the themes that emerged from this is conducting PSGs. PSGs are free to attend, and there's great emphasis on preserving anonymity. The session structure is usually, according to our participants, the session structure usually consists of sharing stories about one another, and also some participants also mentioned that they try to incorporate evidence-based strategies to help aid in recovery. There were also topics such as anger management and motivation related to substance issues discussed in these sessions. The role of facilitators are very different in these peer support groups, as our community is very tightly knitted. The facilitator and the participants have a really strong bond, almost like family, because everyone knows each other in our small communities. So they, other than conducting the sessions, they also take the role of keeping in touch with the participants, calling them up when they are not attending these sessions, and also being very involved in their personal lives as well, such as talking to their families, and also helping them get job opportunities, as well as taking them to treatment centers as well if necessary. The way the feedback is incorporated into these peer support group session is in a very informal manner, where the participants usually just come up to the facilitators or the NGO members and just tell them what they don't like and what they like about the sessions, and they tend to change the sessions based on what the client wants. The next theme that emerged is participation in the PSGs. One of the participants mentioned the lack of new participants and their consistency, meaning that there are very less newcomers coming into the PSGs right now, and even the ones that are already coming are not very consistent in their attendance. Due to this, there's just the same topics being shared and the same stories being shared. And when asked about why this is happening, why people are not attending these peer support groups, they mentioned that sometimes people move on. They get jobs, they get a family, and they just stop coming. They don't have the time to attend. And one other participant also mentioned that when he started recovery and he was still attending these sessions, a lot of people around him were discouraging attending these sessions because he is getting his life back together, and he has a job and he has a family, but why is he still going to these peer support groups and telling people that he has an addiction? So because people don't really understand that addiction recovery is an ongoing process, and it's something that people should be always working for. That is something that people are not aware in the Maldives, we have found out by this study. Nevertheless, there were also upsides to participation. A lot of our participants shared that their families and their loved ones support their participation, and also a lot of facilitators support their participation as well. Facilitators shared that they are always available 24/7, and if they need anything, they are always one call, one message away, which also helped participants be more consistent with coming to PSGs. The positive outcomes from participating is one of the participants shared that the support group gave him the purpose and helped him override his old routines. He was punctual and he was punctual and dressed well to attend the sessions, and it made him feel good, and he learned a lot in these sessions. Another thing was that they have gotten a sense of belonging. They have a place where they can connect with one another, meet people going through the same experience as them, which is very much needed in our small country, where drug addiction is highly stigmatized. Also, moreover, a lot of the participants are contributing to PSGs by being involved either part-time or full-time, so they are trying to make this as sustainable as possible. Another theme that was identified in this study was resource mobilization for PSGs and its challenges. At first, the government did assist in starting up the PSGs, as one NGO mentioned that they didn't have a place to conduct these peer support groups, and the government lent them a place to start their peer support groups. However, due to some issues, that place got taken away too. One of the most biggest challenges regarding conducting PSGs are limited resources. There's lack of funding. A lot of the PSGs that are ongoing in the Maldives right now are funded through themselves, through their own pockets, and because of this, there's also a lack of staff, lack of trained staffs. Very less people in the Maldives want to work for NGOs and peer support groups because there's no pay, there's very low pay, since it's really low funded. As I mentioned before, there is also a lack of space to conduct these peer support groups, and currently none of the NGOs that we had interviewed have consistent meetings because of lack of space. When asked about the visions for mobilizing these resources, one participant mentioned that we can take a percentage of earning from big corporations and include it and make them donate this money to NGOs that are working towards social cohesion and also NGOs that are working to address community issues. Another vision for mobilizing these resources were, in order to get space, the NGOs can, or the government can, collaborate with the Islamic ministry and get their Islamic centers to have space for these peer support groups. That way, it both reduces stigma as well as connects the participants to religious scholars as well. The next theme that I will be discussing is external pressures in running PSGs. There's a high drug use. Drug use is very high in the Maldives, and it's very easily accessible, especially during election seasons. And there's a there's lack of awareness regarding PSGs in the Maldives. The government and the healthcare field do not consider PSGs to be important, since they don't really understand how these are conducted, and they're not aware of how important it is for recovery. And there's a lot of stigma regarding drug addiction as well. So these are all the external pressures in running a PSG. The final theme that emerged from this study is improving PSGs in the Maldives. How can we improve these things in the Maldives? And participants shared that they need more diverse and more support groups in different parts of the Maldives, such as support groups for parents, support groups for patients who are going through methadone treatment, and support groups for people in incarceration. And another way of improving PSGs in the Maldives is also through providing more drug rehabilitation services in the Maldives. And by considering input from PSGs and people involved in PSGs when making nationwide policies and also rehabilitation approaches. In conclusion, we have found that PSGs are very promising for recovery, especially in our tiny nation, the Maldives, where it's very dispersed and it's hard to provide treatment centers in different atolls. And one of the main reasons for having inconsistent meetings is the lack of resources. As I've mentioned before, a lot of participants of PSGs are spending money to have to conduct the PSGs in the Maldives. And the fact that government and the healthcare system of the Maldives are not aware of the importance of PSGs. So we recommend more awareness on PSGs and to integrate PSGs with government rehabilitation services and healthcare. We also would like to recommend more training so that existing PSGs can thrive, as well as new PSGs can come up in the future. And we also recognize the need for drug rehabilitation policy in the Maldives. And in order to do this, we need contribution. We need contribution from people who are involved in this field. So acknowledgements. We would like to acknowledge and thank Dr. Arif Mohammed for his guidance and our participants for sharing their experiences with us. Thank you so much for listening.
Luhya, thank you for your presentation and for highlighting the importance that peer support groups play in the continuum of care, because recovery is often overlooked in the continuum of care and is seen as an afterthought. And in reality, it's so important. And also having evidence-based findings on recovery and peer support groups, which is also very limited in the scientific world. So with that, ladies and gentlemen, I open the floor for questions, and Caleb will be coming around with the mic.
Hi, my question is for Luhya. I'm just wondering, since it's well documented that drug addiction or substance dependency is a medical issue and shouldn't be stigmatized, what steps do you think need to be taken to help remove the stigma in your country? Thank you.
Thank you so much for your question. I think we need more awareness on drug addiction, because now it's like a very taboo topic in the Maldives. It's not really talked about. So a lot of people really don't know how it's going on and what it's like, and a lot of people do not believe that it is a continuous process and that it is a chronic disease actually. So yeah, I think what we need the most is awareness and research like this to like help people be more in touch with what's going on. Yes. Thank you so much.
Yeah, my question is for Dr. Duc. It's about the drug code. We also have our drug law is very much based on the Western principles of drug code, but although we were able to change our drug law in 2011, it's not fully implemented yet. And from your presentation, I saw that you also have some experience. Vietnam also has an experience with the drug court, but one of the things that we are failing to do is to implement the drug court interventions fully, because I think it's in need of a coordinated effort. We don't, in the Maldives, although we have a drug court, we don't have evidence-based treatment. And one of the things that we are seeing is that the current intervention, because it's not evidence-based and it's not well coordinated, it's adding to the stigma. I particularly liked what you said about implementing interventions step by step. If you could elaborate on how you went through, how Vietnam went through it, I think it would be very helpful for us to understand how we can actually counter what is happening in the Maldives.
Yeah, thank you very much for your question. Actually, I've been to Maldives, and I know the difficulties of Maldives, because you have several isolated islands in Maldives. So I think the first difficulty is to coordinate among the people working in the field of drug demand reduction. So back to the questions you are questioning me about the drug court. Actually, drug court is a drug treatment court. It's like a mechanism to support the drug addicts to go through the treatment procedure. So for the drug court, as I mentioned, that the drug treatment court firstly implemented in the US, and now is extending to more than 20 countries in the world. For Vietnam, we also apply a part of this drug treatment court as a pre-trial stage. For this, I think for the drug court, there are some important elements for us in Vietnam. Firstly, we have to have a coordination team. It means that we have to have a team of they are trained to understand about drug addictions, understand how to support people with drug addict, including policemen, treatment work. I mean the person working in the treatment facility, social workers, and also for the judge. If we come to the court, we have to have the team with the judge. So the judge has to be trained on the drug addiction, so that whenever the policeman or social workers refer the case to the court, the judge has to understand about the law and drug addiction, so they can advise the drug addicts and can train them to proper treatment facilities. And the second thing is that you have to have the availability of the treatment facilities. So it means that it will make easier for the team to refer the drug addicts to any treatment facilities. For example, for the synthetic drug users, you cannot refer them to the methadone program. This is wrong. So it means that you have to have availability of the treatment facilities. And the other thing is that you also have a legal system suitable with the drug court. It's not only for the drug law, but also other legal documents to support this mechanism. Yeah, that's what I can share with you. And now we also in the very first stage of understanding and implementing this drug treatment court in Vietnam, with the purpose to support the drug addicts in the procedure of treatment. Yeah, thank you.
Any other feedback, questions, comments? No? All right, so thank you so much. 3 o'clock? Duc wants to go and party now. So thank you for being such an attentive audience. So this is officially the last session. So I hope you enjoy the rest of your stay in Thessaloniki and hope to see you next year at the conference. Thank you so much. A round of applause to our presenters.